Thank you, everybody, for coming, and thank you, Twyla, for inviting me to participate today. I am a physician. I'm in private solo practice, boots on the ground, taking care of my patients. I'm also president of the Virginia chapter of Docs for Patient Care. This is a physician organization whose mission is to protect the doctor-patient relationship, and we'll talk more about what that means down the road. I want to share with you my perspective as a physician about healthcare today and where we're going in our healthcare. In the realm of healthcare reform, we hear a lot about cost, access, and quality. All three are important, but affordable cost and easy access don't mean anything if we don't have good quality. So I want to focus on quality for a little bit. Quality in this healthcare reform debate has been redefined, and it now emphasizes two factors. One is efficiency, which really means your use of resources, which really is a cost measurement. The second factor is meaningful use of the electronic health record. This is really a measure of practice function. Let's look at true quality. This is the issue of what you really want as a patient from your doctor. So I'd like you to take your business hat off for just a second and put on your personal hats. And I want you to pretend that you've had this nagging headache all week, but you've been too busy to do anything about it. But this morning you woke up and your headache was so severe that you couldn't even see straight. You're in pain and you're scared. What do you want from your doctor? You want to choose your doctor, who you want to go to. You hope that your doctor will listen to you, your unique story. Perhaps you've had migraines your whole life, or perhaps you have a brother who died of a brain tumor. You want your doctor to apply his education and his experience and use medical standards, medical sound principles to come up with the best plan for diagnosis and treatment. And you want to know all the choices available to you. And then you want to know that all of these resources are also available to you. And you want confidentiality. This interaction defines the doctor-patient relationship. This represents true quality. Its components are choice of your doctor, individualized care, medical-based standards, decisions made by the doctor and the patient, a full range of options available to you, and privacy. I'd like to step back with you and look at the relationship between cost and quality. And I want you to think about all the goods and services you've ever purchased. There's always a relationship between cost and quality, and it's usually directly related. I'd like to submit to you that in our efforts in this healthcare debate to control cost, we've impacted true quality way too much. We are, in a sense, killing the goose that laid the golden egg. I'd like to discuss with you 4 methods that have been used to control cost that have ultimately led to decreased quality of care. We're all focused on the Affordable Care Act, but I would like to submit that the Affordable Care Act is really an extension of methods that have already been in motion. And so regardless of the outcome of the Affordable Care Act, we must address these methods and how they're impacting quality. I'm going to present 4 building blocks, and if you stick with me, I'll put it all together at the end. The first building block is standards of care. Standards of care are guidelines that inform the physician how to diagnose diseases and how to treat diseases. They were originally set by medical societies based on medical principles. But in an effort to control the use of resources, i.e. cost, insurance companies started publishing their protocols for dealing with disease. And then federal agencies, such as the U.S. Preventative Task Force, started publishing their protocols. And then in the Accountable Care Act, we have the Patient-Centered Outcomes Research Institute, which is an entity that determines the best treatment using formulas that include the cost of treatment based on the years of benefit. This is a formula that determines whether your life is worth treating at your age. So here what we see is a shift from medical principles to cost principles in determining the standards of care. And I'd like to ask you a few questions. Who is setting these standards? Is it a medical institution or bureaucrats? What is the basis for these standards? Is it medical care or cost containment? And what if your unique situation doesn't fit neatly into one of these standard protocols? For example, the U.S. Preventative Services Task Force recently put out guidelines for mammograms. These were in direct conflict with standards that were put out by the American Cancer Society, the American Radiology Society, and the American College of OB/GYN. Your doctor, however, is now compelled to follow these new standards, even when they conflict with the traditional standards. Why and how, I will explain in a minute. The second building block is delivery models. Medicine was based on the private practice model, whose hallmark was choice and the doctor-patient relationship. Again, in an effort to control resource use, i.e. cost, insurance companies developed the HMO concept. This is where the doctor served as a gatekeeper to try and control and manage the resources that patients used. The Affordable Care Act went even further and developed the Accountable Care Organization. Now the gatekeeper is a businessman, usually, who's managing the doctor's use of resources. So here we see a shift from choice and personal relationship to a closed system that restricts the patient's use of doctors and resources. I have another question for you. Patients hated the restrictions of choice in an HMO. Why will they like any better the accountable care organizations? The third building block is payment models. The original model in medicine was fee for service, honest pay for honest work. Every other business works this way. Consumers are aware of the cost, and the consumer has the responsibility to pay. This drives the consumer to look for good value. By value, I mean the best quality at the best price. This is what keeps businesses open, and this is what shuts business down. The consumer has that control. Two things change this. Employers offered insurance as benefits, so patients no longer had skin in the game. And insurance companies, in an effort to reduce costs, replaced their indemnity policies with managed care. This created a disconnect between the actual cost and the service. Service was now bundled into units of care. There were global fees, capitated fees, and episodes of care. The reasoning went like this. If we don't pay the doctor for the actual services rendered, and instead pay a set fee for a unit of time spent, as in global fees, or a set fee per patient, as in capitated fees, or a set fee per diagnosis, as in episode of care fees, this will force the doctor to use fewer resources. The Affordable Care Act took this even a step further, using the power of payment to control your doctor's behavior by championing pay-for-performance models. With this model, the doctor's pay is modified based on his adherence to certain standards. This is what compels the doctor to adhere to standards of care that are set by entities other than the medical societies. His education and experience are irrelevant because if he doesn't follow these protocols, he won't be paid adequately, he won't be able to keep his business running, and he won't be able to see patients. Whoever pays holds the power. Who do you want your physician working for? You, the patient, or a businessman counting his use of resources. So here we see a shift from honest pay for honest work that allows the patient consumer to seek good value to a disconnect between the fee and the service. The patient is no longer aware of the fee, and the doctor's service is measured now by adherence to protocols. The last building block is the electronic health record. Does anyone know how we know what happens in the privacy of a doctor's office? That interaction between the patient and the doctor? This data is captured in several ways. Medical data is captured through insurance claims. Medical data is captured through soon-to-be mandatory reporting requirements. And now we have a new way with the electronic health record. The electronic health record began as a way to organize medical information. In our effort to control cost, the focus became as a way to reduce the duplication of services. Now, with the advent of the Affordable Care Act, we can easily see it being used as a tool to access data about your physician's use of resources. To see how much we've affected quality in our attempts to control cost, I want you to think about the very entities that brought medical privacy to the forefront with HIPAA now have your personal medical information flowing on the electronic health record superhighway to multiple data centers. And you can only hope that there won't be a glitch like what happened to a clinic in the Midwest where all of their clinic records went up on the internet and nobody knew. So let's put all these building blocks together. Let's come back to your morning with a severe headache. Remember how you imagined your interaction with the doctor to be. Now I want you to imagine this new model of care. Your friend recommended a great doctor for you to see, but you can't see him because he's not in your accountable care organization. Once you get to this doctor who you've only just met for the first time, he'll ask you a bunch of questions, and he'll feed your answers into an electronic health record. And the electronic health record will spit out a protocol for the doctor to follow. There won't be any need for conversation because there won't be any choices. And if you want your doctor to do a particular test that isn't on this protocol, he won't, because every move he makes will be captured by the electronic health record. And if he wavers from this protocol, he'll be paid less, and his quality rating will be downgraded on a public website. So in the effort to reduce cost, this has led us to this new model of care, whose hallmarks are restricted availability of doctors and resources, standardized protocols, cost-based standards, centralized bureaucratic control of decisions, restricted options, and loss of privacy. This is our new quality health care. So let's talk about cost, because cost is very important, but we can't sacrifice quality. So as you're contemplating ways to change the healthcare system via standards of care, delivery models, payment models, and what the electronic health record can do for you, I want you to consider a very simple way to lower cost while preserving quality. I want you to think about reestablishing the patient as consumer. This requires reconnecting the fee with the service. Let the consumer purchase his own policy. He won't be tied to his employer, and he has a vested interest in his care. Restore insurance to how it was meant to be, to cover catastrophes. Don't fill insurance policies with mandates for routine care and mandates for care that you will never use. And lastly, make the consumer, patient, and the doctor aware of the actual prices for all the services and medical goods. With the patient as consumer, he will demand value, and the essence of value is the lowest cost for the best quality. Thank you.